Okay. All right. Welcome to Ocular Pathology Rounds on June 26th. We have some good cases for you, and without further ado, let's get started. I am Megan Kleinmans. I'm one of the staff pathologists at Coplow, and here's the first case. So this is an eye from a 11-year, 2-month-old, neutered male domestic short-haired cat. This is the right globe. They noted blood in the right eye. They suspected a tumor. Indeed, so do I. The globe was ophthalmic. There was a deep anterior chamber, unable to see the fundus. They noted a pigmented mass extending through the sclera dorsolaterally and into the retrobulbar tissue. And pretty much similar findings are identified grossly. So hopefully everyone can see the mouse pointer. We've got our cornea up here. We actually have our iris way down here. So indeed, there is a pretty deep anterior chamber, basically from here to here, a very deep anterior chamber. Same thing here. The limbus is about up here, and then anterior chamber is from here to here. In that very deep anterior chamber, we have a lens. So the lens is luxated, at least by gross exam, it's anteriorly luxated. The interesting thing about the lens, and part of the reason why I took this picture, was that it's coated all around in a thin skin of pigmented tissue, kind of cool looking. And you can see the cut face is still opaque and sort of white tan. So we have a cataract as well. And at this point, I've ignored the elephant in the room, which is never ideal. But here we have a really thickened iris and ciliary body, which is sort of tan brown, and you can see a similar mass effect extending into the sclera and then through the sclera into the episcleral and orbital or retrobulbar tissue, just as they said clinically. So that's all the gross findings. Let's head to the scope. Yes, that was the right one. All right. We're still going to have to fiddle with the light a little bit, so bear with us on that. Right. This globe is too big to attempt a subgross, so I'm just going to start at a low magnification view. We have the cornea here. We can tour briefly across it just to orient you. So our cornea is pointing to the right now. And here we have our large mass, very purple and only lightly brown on histologic view, this pigmented tumor. It extends in the iris and ciliary body and again through the sclera into the episcleral tissue. And down alongside the globe into the orbit. So we have sclera here, we have sort of pars plane of ciliary body and choroid here, and then out here in the orbital retrobulbar tissue, a little bit of mass extension. So the extensiveness of this mass is important for its prognosis, and we'll get back to that, but keep that in the back of your mind. We're going to take a closer look at these neoplastic cells over here, actually, because that's what I want to do. In this area of the neoplasm, they really show off some of their pleomorphism, which I like. So that's why we're over here. I want this cell down here. Haha, all in fields. Let me turn up the lights just a little. Yes, okay. So these cells that turn out in this case to be somewhat round looking, but they can range from polygonal to spindle shaped in this type of neoplasm. In this area of the tumor, at least, they're showing off a fair amount of pleomorphism. We have karyomegalic cells, we have cytomegalic cells, we have binucleate cells. A lot of these cells have abundant eosinophilic cytoplasm, but it's often faintly pigmented. So the pleomorphism can get quite high in these tumors. However, the degree of cellular pleomorphism is not a feature with prognostic significance. So they can be as wild looking as they like, and it's not necessarily going to impact your prognosis. I'll give you one more close view of these tumor cells in an area with less pleomorphism, just to give you a sort of sense of what the tumor was like all over. So here's kind of what some of the rest of them over here looked like. This is a feline diffuse iris melanoma without any further ado. And we would call this an extensive feline diffuse iris melanoma. And we use that modifier if it extends into the choroid or into the sclera. And then there are 3 prognostic features for routine light microscopic examination of feline diffuse iris melanoma that are associated with a relatively worse prognosis. It bears mentioning that the metastatic rate of feline diffuse iris melanoma is thought to be fairly low. However, some of them are at least more likely to metastasize than others, and the prognostic features that suggest a relatively worse prognosis are 7 mitotic figures in 10 high power fields or more, tumor necrosis and or extension through the sclera. So in this case, that is true, and then and or extension into the choroid. So the extent, the mitotic count, and the presence of tumor necrosis or not are important prognostic features that should be reported on histologically. The part of the reason why I showed this case is the neat feature here. So we'll go over to the lens, and indeed there's this thin membrane all around the lens of pigmented cells. And some of these may be pigmented macrophages, but a lot of them are likely neoplastic cells. And this shows off an interesting feature. In some cases of feline diffuse iris melanoma, I've even seen these cells climbing along the zonules, and they can climb the zonule ligaments to the lens and carpet the lens, as you see here, although this is the first case I've ever seen kind of giving a blanket all around the lens, which was kind of neat. And let me fiddle with the light again. And we can also see some of that kind of carpeting behavior of this tumor on the surface of the anterior uvea as well. We often associate carpeting behavior with metastatic tumors, but that doesn't necessarily mean metastasis for a feline diffuse iris melanoma. These guys are just very travel ready. They kind of travel places. So that was just a neat feature. I wish I could have found a zonular ligament carpeted with cells to show you, because that's always fun to see, but I didn't see that in this case. The only other thing that this eye has is these interesting little multifocal detachments in the retina and folds, which are not as big of a deal as the large tumor in the front. So there you go. It's important to see the classics or the more common things every so often. And this is an extensive feline diffuse iris melanoma.
Yeah, that's an excellent point, because we, for our daily diagnostic routine, we often assume that feline diffuse iris melanoma cells are more what we jokingly call the landlocked cells, meaning they would stay in the uveal tissue. They tend not to float around or carpet. But I agree with you. I think we have started recognizing that more often than before, this pattern of carpeting surfaces, and that doesn't mean, as you pointed out, Megan, that's neoplastic. One interesting thing is that sometimes we end up at with a differential of either a melanoma or a lymphoma when you got poorly pigmented phytums sometimes. And one of the things that they seem not to do, feline diffuse iris melanomas, they tend not to infiltrate the retina, even though they tend to carpet things like lymphomas do. So I think that still holds true, the fact that they will not go into the peripheral retina.
Yeah, basically, I think the takeaway is just be cautious about over-interpreting sort of carpeting behavior with a phytum, basically.
Excellent point.
And yeah, feline diffuse iris melanomas can do whatever they want in terms of morphology. I've even seen some that basically have like a plasmacytoid appearance and are also poorly pigmented, which are quite a diagnostic challenge. Yeah. All right. If there aren't any questions or comments, we'll do the next case. So this is also a cat. We have a 10-year-old neutered male domestic short-haired cat. We have the left globe, and they note 2 areas of previous symblepharon, and then 10 days ago had an unknown trauma and corneal laceration. No dazzle, and there's retinal attachment by ultrasound and hyperechoic opacity in the vitreous. And that's what they note for this left globe. Interestingly, they also noted that the right eye of this animal was previously enucleated. However, that patient's eye was not in Coplow's database, and we don't have a diagnosis or a reason why that eye was enucleated in this 10-year-old cat. So, however, in this eye that we now have, there are some interesting gross features that we'll point out. So this is an image from the front of the eye when it was still whole, and this is the hemiseptic view on the right-hand side. And there's not much of corneal clarity here, so which is perhaps an understatement, as those around me chuckle. So we have this tan tissue that's sort of raised from the surface, and that is conjunctiva that has been broadly adhered to the corneal surface. And we also have an opaque corneal surface adjacent to that. So it's very abnormal cornea, also an understatement. And on the hemisected view, you can see more of that. So this is theoretically where the cornea would be. It's looking very opaque and white tan. And there are areas where it gets quite thin indeed. There's no evidence of an anterior chamber. There's broad anterior chamber collapse. And the iris, or at least anterior uveal tissue, is basically just broadly fused. And in some areas, it gets so thin that it basically looks like it's not there at all. In addition, the globe is filled with pus, and there is no evidence of a lens, at least on gross examination, which is suspicious for extrusion of the lens, at this point, presumably through a corneal defect. And we'll keep looking at that.
Perfect.
Indeed. Maybe we'll try for a subgross on this one, actually. See how that goes. Not too bad. So we have the front part of the eye here where there should be cornea, and there really isn't anything recognizable as cornea there, which is very interesting. There's also a lot of purple in this eye, and on the subgross view, we still can't see any lens. So again, presumably it's extruded. Let's take a closer look. All right, so now we've rotated 90 degrees clockwise, and the cornea, or artist formerly known as cornea, is on our right. So we have uveal tissue here, which is vaguely discernible by these areas of pigmented, probably iridociliary epithelium, although it's very disrupted and abnormal. And this is probably where iris roughly is, and there is no anterior chamber again, and there's no real recognizable cornea. The cornea is basically broadly replaced by this disorganized fibrous tissue. So as we keep going along, we can see much of the same. So just this disorganized collagen rather than any normal corneal stroma. If you're looking for corneal stroma, you would expect that regular arrangement of parallel collagen fibers that extend across the entire thing. It's part of what makes it transparent by, clinically. And so none of this collagen is normal corneal collagen. In addition, over here, we can make out is the start of probable ciliary body plique. And so the limbus is probably roughly in this area, although it's quite disrupted. And this tissue that's on top of this area is sort of loose collagen stroma. And if we check out the epithelium, don't think actually, it's not going to help us out. There aren't any goblet cells. However, maybe if I was lucky, there would be a couple. Maybe there was. And debatable. No, actually, yeah, look at that. There we go. Okay, good.
Just one, but it's okay.
Yeah, there you go. One is all you need. So this is conjunctiva, and helps us to confirm or support histologically our symblepharon. So we have some conjunctiva fused over what once was corneal surface. Nearly the entire surface is epithelialized currently, with the exception of this one area here, which is really quite thin relative to basically just a thin layer of collagen between the outside world and what was probably once iris stroma. So all of this, basically the cornea being broadly replaced by fibrous tissue and the anterior chamber collapse and at least mostly reepithelialized surface, suggests the sequela of corneal perforation or rupture at some point. And that's something that's interesting. So maybe there was something pre-existing in terms of corneal disease, despite their describing a laceration just 10 days prior to enucleation. So sort of an acute trauma, perhaps on a chronic corneal condition. The other things that we see here, there's certainly a really severe uveitis and endophthalmitis. There's lots of suppurative exudate inside the globe. In fact, let's go ahead to our little dot here. And we'll see if the camera cooperates or if my skill with it cooperates. or lack thereof. And there's a lot of nuclear debris about, so it's kind of difficult to be convinced of bacteria, but there were at least some areas where I was reasonably convinced. But we'll see if I can convince anyone else. Debatable. Let's see. I don't know if I'll be able to get the camera to cooperate.
Sure, blame it on the camera.
Yeah, that's exactly what I'm gonna do. It's the camera, you guys. It's definitely, there were definitely bacteria here, trust me.
Antibacterial camera.
So some of these LBDs or little blue dots in the macrophages seemed relatively uniform to me, and I thought they were reasonably convincing for bacteria. However, it's difficult to convince you at this point in time, and we'll just move along and go from there. All right. And just a few kind of cleanup things. We can see the retina. Maybe a little bit less light. There we go. We can see the retina here, which is mostly or nearly completely detached, although there's some areas that are still attached. It's very, very severely atrophied, a little inflamed. And that's kind of what we've got here. So this is basically an acute on chronic sort of a case. There was probably pre-existing corneal disease. Oh, wait, shoot. Hang on one second. I was about to move along without showing you something interesting. Hang on. All right, so I showed you the symblepharon, and the thing that I forgot to show you is over here, near where the limbus probably is roughly. And in that area, sort of in the deep conjunctival substantia propria / episcleral collagen or so, we have a couple of tubules of epithelium, which often present a sort of conjunctival character. And maybe I'll find goblet cells, but maybe not. So we have these tubules or cysts of epithelium that are embedded in this tissue here, and we call these conjunctival inclusion cysts, which probably goes along with the symblepharon, with the conjunctiva fusing onto itself. So that is the last thing that I wanted to show you. And then this is basically an acute on chronic type of a case, likely a pre-existing corneal disease. With a more recent trauma. We didn't necessarily see the site of corneal laceration, so that was sort of an as per history diagnosis. And presumably the fibrinosuppurative endophthalmitis occurred with the trauma, introducing bacteria into the eye. Again, the aphakia may have happened long ago. Presumably the lens was extruded through a corneal defect. And then the final thing to note is that symblepharon with conjunctival inclusion cysts is supportive of feline viral disease, especially herpes viral infection, although not specific for it. So consider the potential impact of viral disease on the corneal health of this patient.
Herpes more specifically, right?
Yeah, herpes virus, especially herpes virus, yes. Although maybe calicivirus, but probably herpes virus far and away, most likely
I thought they had
FH1.
mentioned long-standing symblepharon in the history, didn't they?
They did.
Okay.
So yeah, there's evidence clinically of pre-existing corneal disease as well. Plus the other eye was enucleated, if you recall. So I kind of wonder if it was similar sort of herpes viral related disease or bad corneal disease, maybe long-standing through the patient's life. Yeah.
With a caveat that we tend to blame herpes in cats for lots of things.
Yes, indeed.
But it's an educated guess. Let's put it that way.
Supportive of, not specific for.
Right.
All right, I will give the microphone to Dr. Jamie Miller, one of our wonderful staff pathologists.
Yes. The cat thought it was a rabbit. Yes. Yes. So yeah, this is my representation of the gross picture for this case. There were no clinical or gross pictures of the globe because it wasn't super remarkable grossly, but I thought this was a nice potential clue for what we're going to look at today. So what we received was the right eye from a 2-year-old, 4-month-old spayed female domestic medium hair cat. The history was that there was absent menace and brown keratic precipitates over the ventral 25% of the corneal endothelium. There was 2+ aqueous flare with 3+ fine white cells in the anterior chamber. Rubiosis iridis, and tropion uvea, mature cataract with radial pigment on the ventrotemporal anterior lens capsule, and a small foci of pigment on the dorsonasal anterior lens capsule. They were unable to visualize the fundus. There was no glaucoma in this eye. The other eye was not normal, and they describe early immature cortical cataract that was reaching toward and contiguous with the anterior lens capsule, which they were suspecting was secondary to a previous trauma. And they also note embryologic lens nucleus visible. Grossly, like I said, there wasn't much to see. We did think that the lens looked like very cataractus, and that the vitreous was thin, and that was about all. So I'll go straight to the histology. All right. Get us oriented here. All right. So cornea up at the top here. We can see our iris leaflets, which are a little bit more blue than they should be. Here is our cataractus looking lens, more blue in there than there should be as well. And then the back of the globe was kind of quiet. This is a deeper section. We don't quite have the optic nerve head, which was pretty normal in the superficial section, but this one shows the main event a little bit better. So we've got a more complete view of the lens in this case. All right, so let's walk us back towards the front of the globe here. So again, cornea looking pretty normal. Here, go on this side, ignore that piece of tissue that's floating in the anterior chamber because it has nothing to do with this case. So there is some lymphoplasmacytic inflammation in the iris and ciliary body stroma. Occasionally they are forming little follicular aggregates, kind of lining the pectinate ligaments and doing typical things that a chronic lymphoplasmacytic uveitis in a cat does. The main event, though, is this lens. Drop over here. Here's kind of the overview of the lens. We can see some of the dark basophilic material, which is mineralization of the lens fibers. And then we've got degeneration, liquefaction of the lens fibers, more ganglion globules. Oh my goodness. It's nice little rounded up portions of the degenerate lens fibers. And then there's this sort of this lighter blush of blue that's in here. And I'm gonna head just towards the back because I thought it was a little bit better here. And this was originally what caught my eye as we were going through looking at this very cataractus lens. We've also got posterior migration of the lens epithelium. Here's the light, there we go. We also have some macrophages in here. So you should have macrophages within inside your lens. So there's lens capsule rupture somewhere, and I don't think I caught a very great section of it. But most importantly, get these to show, and it might be difficult, are these colonies of these critters that are a few microns in diameter and a little bit bigger than what we typically associate with like cocci bacteria. So they stood out a little bit more, but they're about the right size for what this organism should be. And as we look, you can see that they're just everywhere. They're dotting everywhere throughout this lens. There's just a ton of them. Let's see. You can see them in the front of the lens. go. Ooh, too high.
But that you mean the anterior.
Yes, the anterior portion.
Right.
Yep, here's a thicker anterior lens capsule. We did have this area kind of right here in the posterior iris and ciliary body. There's some like collagen and more mineralized lens fibers that are kind of free. So, and some more macrophages. So again, more evidence of lens capsule rupture in this case. And then the organisms within the lens itself, that are a little bit larger than our typical bacteria. The retina and optic nerve head were fairly unremarkable, which goes along with their no glaucoma. So I put on a gram stain for these critters. Which highlights them in this nice blue gram positive staining. Closer. So again, like 2 by 1 micron organisms here that show up gram positive. And then interestingly, I did a acid fast stain because they can often get highlighted as well with the acid fast. They're very rarely acid fast positive on the stain. But this, oops, correction. But the stain kind of helps highlight them if they were maybe, say, not this numerous amount of organisms here. Let's see, probably gonna be really hard. There's some red here, maybe even here. So there's like very rare positivity on the acid fast stain. It's capsule. Awesome. Comment that the staining is in the capsule of these organisms. So capsule in the organism, so not bacteria. And putting it together with their clinical features and the gross photo. So this is a hypermature cataract with lens capsule rupture, granulomatous phakitis, and those organisms are consistent with their size, shape, location, and staining pattern with the specials with Encephalitozoon caniculi, which if you're familiar with this organism, this microsporidian organism, it's often seen in rabbits, hence the name, and hence the gross picture that I put up there is a cat with rabbit ears. There are some reports out in the literature of this rarely causing cataract disease in cats and a phakitis uveitis. So it's something to keep on your differential list if you have a cat that presents with those signs. I think we often attribute it to like maternal transmission through the fetal vasculature vertically. And so these animals are kind of born with it, and then it kind of progresses, and then it presents with cataract and phakitis there. So, and then if you remember that they did report cataract in the other eye as well. So that would sort of go along with potentially a maternal spread for this organism in this kitty cat.
Yeah, they kind of describe the cataract in the other eye kind of in
Like a
interesting
weird,
way.
yeah.
What was it again? They said something about.
Yeah, they said that it was an early immature cataract, cortical cataract, reaching toward and contiguous with the anterior lens capsule, and that the embryologic lens nucleus was visible.
Right, yeah, that was the weird thing. We weren't sure what that meant, but there's a word embryologic there, so it makes me wonder if they were thinking about something maternally transmitted, like you would expect.
Yeah.
So why not toxoplasma?
So why not toxoplasma?
They can repeat that.
So the question was, why not toxoplasma? These guys look quite big for toxoplasma is really teeny tiny.
I think it could,
And
well, I think it's a possibility, but the distribution in the lens, it's kind of classic for E. cuniculi.
Toxo doesn't stain with gram stain, does it?
Yeah, I don't think it's gram positive. It's gram positive.
It can.
Yeah, it can.
so toxoplasma can stain gram positive on.
Mhm.
I don't think I've ever heard of toxo being in the lens.
Right.
Which is my bias.
That's what I was wondering, I've never heard of being in the lens either.
Yeah, but then again, I'm not sure how many of these we've actually delved into, could
Yeah.
possibly be something else.
There's the single famous case where it was in the corneal epithelium of all places.
True. True.
Yeah, so
That's not
it's
strong supporting evidence.
yeah.
No, but the single case is strong supporting evidence, come on.
I was just curious because I would have had that on my list as well, even though I've never seen it or heard of it.
Mhm.
Yeah, toxoplasma would also be a good, I guess, differential to keep in mind, although we're not,
Based on morphology of the organism.
based on morphology. I see a chat bubble pop up. Is there something in the chat? We're not sure that we've seen toxoplasma within the lens itself.
Here are some things here. People are chiming in.
Yes,
Kelsey
I
said
love
she
it.
thought toxoplasma was gram negative, gram stain.
I mean,
Okay.
Probably,
Yeah.
but I think I've seen it gram positive.
Billy wants to know if they're obligate intracellular. Many organisms appear to be extracellular. I don't think they're,
No,
No.
they have to be outside of the cell. at some
Yeah.
point.
Cunicular or not.
no.
Neither are toxo, I don't think, right? I mean, they break out of a cell at some point and they're infectious.
But, yeah, but then-
Here's a question. So Aline wants to know, didn't understand if the encephalitozoon led to the cataract or the cataract was already there. The infection occurred. So the idea here, Aline, is that the infection happens during pregnancy, and the encephalitozoon organisms would reach the lens through the embryological vasculature of the hyaloid artery. And then when they get into the lens, they start proliferating, and then they will lead to the cataract. And with time, the lens degeneration just gets worse and worse, and lens capsule, and then it evolves to lens capsule rupture. Then they have kind of a secondary lens-induced or organism-induced endophthalmitis or reaction around it.
Gram stain can be used to detect toxoplasmic gondii spores because they are gram positive.
Spores, maybe. Where are you reading that? Like everywhere else is gram negative.
All right.
There's some question on whether toxo is gram positive or gram negative. We've got majority of sources saying negative, but some saying positive, so maybe they're variable.
Another question here, where did Dan get the bug from rabbits? That's a good question. Likely, I think that's a possibility. So E. cuniculi are, reading on them, they can be seen in lots and lots of species, or they can infect lots and lots of species of animals, but we don't know, don't know necessarily. So Kelsey said, does it depend on the cyst or tachyzoid form, positive or negative staining? Yeah, we're diving deep into the tinctorial properties of the cuniculi. We will get back to you guys in 2 weeks about that. But those are good questions.
I just want to pipe up with one annoying comment that I personally would never use the species because we cannot speciate.
Yeah.
So I would typically just say encephalitozoon species.
That's right.
Mhm.
Yeah.
Because who knows what it actually is.
Yeah.
Right.
And there are different encephalitozoon.
Yeah, there are many.
Mhm.
So.
That's fair. Yeah, and I think we've only had one other case of this in a cat. There's maybe a couple in dogs. I think there was
But it
a,
appears to be a more recognizable syndrome in Europe.
Yeah.
Encephalitozoon.
Most of
related
the
cataracts.
most of the literature about echiniculi or encephalitozoon in canids is actually out of fox fur farms in Russia from the 70s. Which I read extensively about when I was writing up the previous case that we got that really needs to be submitted for publication in a dog. So anyway, yeah. So it's well, there are like a series of papers about foxes being affected.
Yeah, this is the best one we have by far in terms of like
Yeah.
how clear they were in there and the
Yeah.
quantity of organisms, and the bilateral history is very interesting too, which suggests systemic infection.
I think the other feline case that we have is actually the stuff from cataract surgery.
Oh yeah, from mid-Caesar.
So they actually done cataract surgery and submitted some of the stuff. And we actually found the organisms in the stuff from the lens. So
The phaco product, I don't know, what do you call them?
the aspirated material.
Aspirates.
The phacoemulsificant.
Yeah, the phacoemulsificant. Okay.
All right, awesome.
Okay.
Good discussions and comments and such. All right. So this next case is going to be a clinical photo that one of our clinicians was kind enough to send us for this case. This is a 5-year-old female spayed German Shepherd dog, is what they called this, with the left globe being affected from the picture. So they report blepharospasm and incomplete blink, mucoid discharge, as we can appreciate here. There's chemosis and hyperemia, diffuse corneal pigmentation with what they call a ring of pink granulation tissue. They were suspecting a mass effect with a secondary glaucoma and inflammation. They said yes to glaucoma with the IOP of 55. They said for duration of this problem, that this probably started about 1.5 years ago, but worsened within the last week, secondary to running into a door / trauma. The other eye, let's see nicely here, they report as normal. It does look like this dog went to see an ophthalmology specialist because they were concerned because this dog has a very subtle but very distinct line of demarcation where half of the dog's head is a different pigment color than the other half. And so they were suspicious for this entity and suggested histopath. And so they were kind enough, once they removed the eye at the RDVM, to send it to us. So here on the left is the front view that looks very similar to the clinical picture with all the pigment coming in here in this sort of opaque rim at the front. Here's the hemisected view. We can see that there is cornea at the top, lens looking pretty good here in the center, lots of pigment in the entire uveal tract. And then it gets really thick back here, and we kind of lose a little bit of definition of the posterior sclera here, and with this really thick brown tissue. And then I think some of this here tissue is retina that has been detached. So we'll look at this. All right. Go. All right, so cornea up at the top, very hypercellular, with here is the edges that are pigmented, and here the center would have been probably opaque, that opaque color. And this pigment, again, kind of traces through the limbus and throughout the entire uvea. Uveal tract is maybe a little bit thickened and distorted. And then the globe was so big that we did have to do a Swiss roll where we make an incision into the globe and kind of wrap it around itself to fit in the cassette. But back here, here's the optic nerve. where our optic nerve head should be. And then there's this mass effect that we were seeing on the hemisected view. All right. That's as low as we can go. So starting up front here in the cornea, we can see the hypercellularity and all the pigmented cells that are coming in. The cornea epithelium is a little bit hyperplastic. There's lots of neutrophils, lymphocytes, plasma cells in this cellular infiltrate. And then this, also what's in here are these acicular clefts of cholesterol with these associated macrophages here. So there's also a lipid keratopathy in this eye.
Which is what gave it that bright white or bright pink appearance.
Yes, thank you. All right. So again, as we travel back into the uvea, it's very heavily pigmented, and our pigmented cells do kind of extend into the sclera. Yeah. See if I can. We follow some of these cells here. We do get pigmented cells kind of perivascularly in the sclera, in the episclera, and in sort of the tissues surrounding the globe, which is a little bit unusual. And then again, a little bit of distortion to the iris and ciliary body parenchyma with all these heavily pigmented cells, which when we get distortion of the uveal tract by the pigmented cells, we usually diagnose this as uveal melanosis. But as we head towards the side that has pretty, there we go, marked expansion of the choroid here. This is more leaning towards the neoplastic population of melanocytes here. It's going to be a little bit hard to see given how heavily pigmented they are, but they're polygonal to occasionally spindle cells. Let's get that in there. So heavily pigmented cells can sort of barely make out the nuclei, finely stippled chromatin, prominent nucleolus occasionally. There were no mitotic figures in here, making this a benign neoplasm, so a choroidal melanocytoma. There's a little bit of hemorrhage, a little bit of necrosis in the mass as well. And then sort of as we saw kind of grossly, there is some extension of the mass outside the posterior sclera. It is maintained within some fibrous connective tissue, and it did look clean grossly. We did trim a little bit of tissue off the globe, so they did get clean margins. The other thing is that the retina and optic nerve, retina is detached, because that's as low as I can go. There's a lot of free pigment cells here, but there's also in the optic nerve head, there's not much recognizable tissue left, and it's kind of all replaced by Gitter cells. So foamy macrophages of the nervous system that are replacing the parenchyma here. And here we go. And in the retina, that is detached. Our ganglion cells have this bright eosinophilic cytoplasm and poorly staining nuclei, which is consistent with acute necrosis in the retina. Call those dead reds histologically, because they're quite bright pink / red. Sometimes they can get pycnotic and shrunken as well. So a little bit more acute changes for like glaucoma and necrosis in the retina and optic nerve head. So maybe that has to do with the trauma that they reported recently, more so. And I think that was all the main portions, and the lens was pretty unremarkable. So, so this case had a lot of things going on. It had that choroidal melanocytoma with kind of scleral and orbital extensions, but they got clean margins on it. But the atypical pigment there with the melanosis and kind of extension of the pigment around blood vessels in the stroma and around the different areas of the eye. It was a little bit mild in this case, and a little bit complicated because there was extension of that melanocytoma. So it was a little bit difficult to pick out if those were plastic cells or just heavily pigmented macrophages. But with the clinical appearance of the like distinct demarcation of the fur coloration in the head, those are supportive of ocular dermal melanocytosis, or what's called Nevus of Ota. And again, we had the lipid keratopathy in the cornea, the retinal detachment with kind of more acute retinal necrosis, and then glaucoma, kind of acute from what we're seeing histologically, and maybe chronic from what they were saying clinically. This is interesting case. Just I think I've covered most of it. We've seen these with these sharply demarcated fur colorations in the head.
Yeah, it's assumed to be a
yeah.
congenital abnormality of atypical migration of melanocytes from the neurocrest. The Nevus of Ota term is directly borrowed from human medicine. Those are very interesting. You see pictures of individuals with that, and they have, it's not obviously, black and not black, but they have a kind of a diffuse grayish coloration of half of their faces. They have sort of lots of nevi, lots of darkly pigmented spots around the face, and they tend to have similar lesions in the sclera and conjunctiva. So it's appears to be a congenital, or a migration of these melanocytes. And you can see them when you look around. There's a lot of these melanocytes that go with bundles of nerves and arteries and vasal bundles, like they've been migrating through embryogenesis. But the cool thing about this is that we've both seen that version of it, where it's just a heavily pigmented globe with those changes, but also cases where not only they have that, but they also have multiple melanocytic tumors and lesions associated with it. We have a few cases where, kind of like this one, they develop uveal melanocytomas, but they also develop eyelid and conjunctival melanocytic tumors, melanomas and melanocytomas. And I think it's just a matter of the chances of one of these cells becoming neoplastic just increases because they're everywhere. But it's kind of a cool association there.
Awesome.
So there's a question: what's the current thinking about the frequency of melanocytosis progressing to melanoma? That's a good question. I don't think we have data in numbers to kind of come up with a percentage of that, but we do see a fairly, well, we do have a good number of cases where we have both melanosis and tumors at the same time, and we often assume that it's a progression or part of it, but rather than finding them together, I don't think we can expend too much in terms of numbers or the directionality of things, you know, if one started first and then the other developed, or if the one predisposes the other, which I think is the most important thing. But that's a good question.
All right.
Interestingly, I think Cairn Terriers, who are obviously the kings of uveal melanosis, I don't think we have very many of those with melanocytomas.
Yeah, good point.
Interestingly, it's other breeds that seem to develop the melanocytoma on the background of uveal melanosis.
Yeah, which I guess hammers down the point that they might not be a continuous process, you know, melanosis to, they may not be like a directional relationship there.
Or it's also possible that Cairn Terrier's variety of uveal melanosis is quite different than that that develops in other dogs, other breeds. So which I think we kind of feel is true, but it's hard to get to the bottom of that. All right, so I have limited time. So I'm actually gonna skip this
Kelsey
case.
also raises a interesting, sorry, you know, your guess that, do you think Cairn Terriers with melanosis are nucleated before melanocytomas can develop, since clinicians are
The opposite.
Yeah.
Actually, I think Cairn Terriers are often enucleated much later in the disease than other dogs, in part because I think it's recognized as a problem. So clinicians see it and they're like, oh, it's melanosis. It's not a tumor. There's no reason to enucleate this dog until the glaucoma is out of control. Whereas in other breeds, I think it's less well recognized. And so there's a greater concern that it's a neoplastic process. So they're enucleated earlier.
Yep. Excellent.
All right. I'll show that other case maybe next time because it's pretty cool, but pretty complicated. This is a less complicated case. So I think I'll just show this one. So this is an eye from a 1.5-year-old mixed breed dog, spayed female. We actually received this dog's other eye. So now it's an eyeless dog. Back in early 2024, so probably January, given the case number. I don't have that information with me, but anyway, so the history that, and I showed that globe actually back in January. So that one was received the history of the dog having TVT, or a transmissible venereal tumor that had been treated, and then its other eye developed a problem. And so they enucleated it, and I will just go ahead. Well, I'll show you the initially enucleated eye. But then unfortunately, recently we just received the other eye. We received it in mid-May, and this is what it looks like. And so the history we got was that the dog was out of remission for transmissible venereal tumor since April 16th of 2024. And then they say enucleation performed concurrently with left mandibular lymph node excision. We only received the globe, not the lymph node, so I'm not quite sure what happened to the lymph node. The dog is currently receiving vincristine, and a CT performed the day before this second eye was enucleated showed no further metastasis. So hopefully they can get ahead of this dog's metastatic TVT problem. But anyway, so here's the globe. Obviously gross photo. It has the mass itself actually has a unique appearance, which may have initiated the taking of a gross photo, but with the history, we wanted to take a picture of it as well. So we have an off-white mass that expands and infiltrates and expands. The iris and the ciliary body kind of ends short of the choroid, but greatly expanded there. So let's just go ahead. And really the rest of the globe is pretty normal. They reported no glaucoma. So I don't think we have the best view of the optic nerve here. In fact, I'm not sure this is the half with the optic nerve. I think it is actually, because this is probably the optic nerve. Anyway, we can't see the optic nerve head very well, but anyway. All right. Here's our subgross view. Cornea is to the left there. So there is our greatly expanded, actually looks like the ciliary body is mostly the problem on this side. Let's check out the other side. So it's very densely cellular. That's why it's so very purple. Same with on this side. And yeah, actually, I was wrong. The iris is not affected. It's mostly in the ciliary body. And I didn't see it anywhere else. So I looked in choroidal vessels. I didn't see it anywhere. It's extending into the very far peripheral choroid in this area. So ciliary body expanded, effaced. A densely cellular neoplasm. Oh my gosh, playing with two dials is hard. All right. They are round cells with relatively distinct cell borders. Kind of small amounts of wispy eosinophilic cytoplasm and these great big round nuclei. Oh, the camera just doesn't want to go any higher than that. Great big round nuclei with coarsely clumped chromatin and single fairly prominent large nucleoli. Some of them have some pigment in their tummies. It's also possible that those are macrophages. It's hard to say exactly. There are mitotic figures around. Let's see here. I didn't write a description for this one, so I don't know how many there were. But this, obviously the history is pretty supportive of this being TBT. But not cytologic, but the histologic features of TBT are round cells that are fairly large, and they have sort of vacuolated cytoplasm and variably distinct or specific nuclear features. Cytologically, they have vacuolated cytoplasm, which is very characteristic. So it's a much easier slam dunk diagnosis on cytology than it is on histology. If we wanted to confirm it, we could either do a PCR because these tumors have very specific genetic abnormalities. So there's a PCR that can be done on formalin fixed paraffin embedded tissue if you ever need to do it. You can also do a whole series of immunohistochemical markers because basically you have to rule out all the other types of round cells. So you'd have to rule out all of your lymphocyte types, your histiocytic types, and I guess mast cells, although it's probably lower on the list. And probably I'm forgetting some. Why not a melanoma? I mean,
Right.
Got to rule out everything. But one of the more characteristic ones is if you do lysozyme and it comes up positive and they're also negative for CD3, then that is somewhat supportive because T cells can also express lysozyme. So anyway, that is the gist of this case. Kind of a short but sweet one. Sad for the dog that it's now eyeless, but as I said, hopefully they will get ahead of the metastatic disease.
Yeah, as a Brazilian being in the US, I'm happy to come back to use this moment with TBT because in Brazil, it's training there. It was an obvious differential, but forgot about it for a while here. But I don't know if what's happening, if it's just normal spread of this tumor, but it's being we've been seeing more often.
Yeah, I think there might be a higher number of dogs being adopted from other countries
That's
these
true,
days.
too.
I'm not sure if that's really true or not. This is the previously enucleated eye. And I'm trying to remember where the juiciest part here. I guess it's here. So we have this population of cells that's carpeting the ciliary body and the zonular ligaments and the lens, which is nice to reiterate what Megan said earlier. That metastatic tumors, when seen from the perspective of ocular pathologists and ophthalmologists, tend to carpet intraocular surfaces, whereas general pathologists would tend to see them more intravascularly in the choroid with necropsy cases and such. Anyway, so we have this nice carpet of round cells on the surface of the intraocular structures. So this was the first globe that was enucleated from this patient. And at that point, we'd already had the history of a TBT. So
once again, it was kind of a slam dunk. Like, yeah, that's TBT.
Mm.
Occam's razor. So that is about it. So I think that's it. We will conclude rounds with this case. So thank you all for your attention and have a lovely Wednesday.
Thanks, everyone.